بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. إن شاء الله النهاردة هنختم ال European Society of Vascular Surgery guidelines, and we'll talk about our last topic in these guidelines, which is acute limb ischemia in children. We'll talk about the epidemiology, diagnosis, and treatment options and outcome. And as regards the epidemiology and etiology, acute limb ischemia in children is rare, but potentially catastrophic event may be associated with mortality, limb loss, and permanent long-term disability. In most instances, actually, ischemia is iatrogenic and results from thrombosis secondary to umbilical or femoral artery catheterization, especially in neonates and young infants. Symptomatic thrombotic complications occur only in 0.2% of neonates in the intensive care units. However, asymptomatic catheter-related arterial thrombosis is much more common, ranging from 3 to 90%. Other causes of acute limb ischemia or other etiologies of acute limb ischemia rather than the iatrogenic may be penetrating or blunt trauma, cardiogenic embolization in infants with congenital heart or great vessel malformations, or inborn coagulation disorders, or an intrauterine extrinsic compression. And here we can see in this table the etiology of acute limb ischemia and approximate relative frequencies in children. And as we can see, the most common is iatrogenic, followed by the traumatic etiology. And as regards the diagnosis, clinical presentation of acute limb ischemia in neonates and small children may be less obvious than in adult population. So a high index of suspicion is necessary, especially when arterial catheterization or when there is a history of arterial catheterization was performed. This can be explained, and the difficulty in clinical assessment of the acute limb ischemia of children can be explained by the limited capacity to verbalize the complaints, and also smaller limbs and less developed muscles, which are more tolerant of hypoxia. Furthermore, collateralization may be improved and develops rapidly early in life. So how to diagnose the acute limb ischemia in children? Actually, the most common presentation is cyanosis and delayed capillary filling, and maybe temperature difference between both limbs. Necrotic changes are less frequent in children. Infants versus older children had a lower risk of upper extremity acute limb ischemia, and as we will see, upper extremity acute limb ischemia has a much higher incidence in older children due to the presence of or the possibility of occurrence of a supracondylar humeral fracture, higher mortality, and were more often treated without intervention. And here we are talking about the infants. Several publications have suggested that duplex ultrasound is a useful guide to do a vascular puncture in this special category of patients to minimize the incidence of catheter-related arterial thrombosis, and also for the early diagnosis of thrombotic complications. What about the treatment options? Actually, the treatment options are either anticoagulation or thrombolysis, which may be either systemic thrombolysis or an endovascular thrombolysis or an endovascular intervention and a surgical intervention. What about the anticoagulation? Conservative management with systemic heparinization has been the mainstay of acute limb ischemia treatment in children, mostly based on expert opinion and a small case series, as literature is scarce in this topic. Anticoagulation alone appears to be a relatively safe early strategy in the majority of cases, allowing a partial or even complete resolution of thrombus and development of collaterals and recovery of limb perfusion at the price of a small risk of bleeding complication, which is 3% in one investigation. What type of anticoagulation to be used? Both unfractionated heparin and low molecular weight heparin can be used. And for unfractionated heparin, a bolus of 75 international unit per kg, followed by a perfusion at 28 international unit per kg per hour for infants less than 1 year of age, and 20 international unit per kg per hour for older children is generally used. and adjusted according to the ABTT time to be between 55 and 85 seconds. What about the systemic thrombolysis? As we saw before in the treatment of the acute limb ischemia in adults, actually systemic thrombolysis is not recommended, but successful treatment by systemic thrombolysis is reported in children presented with acute limb ischemia. There is a high risk of intracranial bleeding, and especially in preterm infants. What about the long-term outcomes of conservative management have also been evaluated, suggesting that 15% of the affected children will have either intermittent claudication, and most important thing is limb discrepancy as the child is growing, as the neonate is growing, and the blood supply to the limb is less than the other limb, so there may be a limb discrepancy as a result of the impaired growth later in life. Infants and young children present significant technical challenges for revascularization, and the surgical outcomes are worse than those of older children, and this is expected as the blood vessels are much smaller than older children. So infants in particular do not have an improved outcomes after surgery when compared with those treated conservatively. Endovascular treatment is an option, and it appears to be a safe strategy and may be used selectively in most severe limb-threatening cases. What about a special circumstance, which is the supracondylar humeral fracture? In school children, actually supracondylar fracture of the humerus is a common cause of an upper extremity acute limb ischemia. This entity results from brachial artery injury, and the majority of cases resolve after a closed reduction and stabilization of the fracture. When severe signs of acute limb ischemia are present, exploration is advisable. However, some limbs remain pulseless despite apparent perfusion of the hand. And presence of apparent perfusion of the hand without a pulse is called the pulseless bank hand. And the management of the pulseless bank hand is more debatable, as many authors actually recommend watchful waiting, as symptoms usually resolve and the pulse return within 1 week. But here in the guidelines, there is no mention about presence or absence of Doppler signals. It is a perfusion only. But in my opinion, to build your decision on presence or absence of Doppler signals is advisable. So if you found the Doppler signals in the patient after a closed reduction of the supracondylar humeral fracture, you can do a watchful waiting with follow-up of the patient after 1 week, and pulse may return within 1 week. Exploration actually is reserved for patients who develop additional signs of ischemia or those without improvement after 1 week. So you may build your decision on presence or absence of Doppler signals. If the Doppler signals are not there, so do an exploration, as actually in most of these cases the brachial artery is entrapped in the fracture of the humerus. So exploration to release the brachial artery entrapment at the fracture site may improve the condition. You may do a primary arterial repair, you may do a venous patch angioplasty or a venous interposition grafts, and all of these options appear to be the preferred surgical options in management of a supracondylar fracture of humerus. What are the recommendations with the guideline for infants and children younger than 2 years of age? With acute limb ischemia, initial conservative management with heparin is recommended, and for infants and children undergoing femoral catheterization, ultrasound guided puncture and post-procedural ultrasound examination should be considered. And for infants and children with acute limb ischemia without improvement after conservative therapy with heparin, thrombolysis or open surgical revascularization may be considered. But we have to know that outcomes post-surgical intervention, and especially in the infants, are very poor. In school children with a supracondylar humeral fracture and the pulseless perfused hand, watchful waiting may be considered an alternative to immediate surgical exploration. And by this we reached the end of these guidelines, the management of acute limb ischemia. الحمد لله بكده نكون خلصنا ال European Society of Vascular Surgery Guidelines for the Management of Acute Limb Ischemia. لا إله إلا أنت سبحانك إني كنت من الظالمين. الحمد لله الذي بنعمته يتم كل صالح وبفضله ييسر كل عسير.